Superintendent Grace, take the next minute or two to refill your coffee or refill your plate, and then we'll get started.
Thank you. Yes, that was. I almost, it brings me to tears. So I'm so proud of that part.
Like I should have mentioned when we're in the discussion.
Well, I think it was really, it was just so fitting for this.
Yeah, that's the spirit. I don't think that. Just melt. Before I introduce Paul, we have a birthday boy among us. Bill, would you stand? This is our beloved Bill Hayden, who turns 85. Was it today or this week? Yesterday. And his wife very lovingly made sure we had a birthday cake. Could we sing happy birthday to Bill? Happy birthday to you. Cha cha cha. Happy birthday to you. Cha cha. Happy birthday, dear Bill. Happy birthday to you. And many more. So welcome. I am the Reverend Misty Kiwak, pastor here at Grace. Thank you for joining us. This is the end in our summer science series. I'm so very grateful to Paul Vinsel for being here. He's a new parishioner and he got nabbed for this pretty early on. So thank you, Paul. Paul is a physician who spent many years in emergency medicine, 36 years before deciding to specialize in addiction medicine. He's with Spurwink at the Family Medicine Residency at Central Maine Medical Center. We are so grateful he's here, so grateful that he jumped into this as a pretty brand new parishioner. Please give Paul a hand.
Thank you very much, Misty. Let me know if you can't hear me. I'm going to be picking this up. I'm going to channel my best Mick Jagger here. I want to thank Misty for asking me to do this. What I've always found is whenever I do a talk and do the research for the talk, I learn so much more. And it gives me so many more tools. Gary and I were just talking about that. It gives me more tools to help my patients. And that this talk has definitely done this. Misty gave you a little bit about my background. I spent a long time in the emergency department. And then for about 3 or 4 years, I gradually transitioned, some working in the emergency room and also working addiction medicine. And then in 2021, I stopped the emergency medicine practice and just do addiction medicine now. I want to give this talk in 2 different sections. The name of the talk is The Role of Spirituality in Recovery from Addiction. But before I talk about that, I want to talk about the neurobiology of addiction. The reason I think that is so important is that it was the major influence in me switching careers. And I think it's really important to decrease the stigma associated with addiction and substance use disorder. By the way, substance use disorder is the medical term for addiction, so I will use those 2 terms interchangeably. The way I'd like to start this, I'm gonna use the whiteboard over here, and I don't know if anyone told you, by the way, welcome to all the guests here besides the parishioners. I really appreciate you coming in. Also, if you have any questions or comments throughout the talk, just raise your hand. We can interrupt. The questions and comments are just as important as the talk. What I'd like to do to start is get some audience participation here. And I want to hear some from you. What do you think are some of the reasons why people would use a substance for the first time? And substance could be anything. It could be alcohol, could be cannabis, could be opiates, could be cocaine. People start their journey in addiction through a lot of different sources. But what are some of the reasons why someone would use for the first time? Yes,
Curiosity for the young,
curiosity.
especially, I mean, I was gonna say pain, but then I thought youth. Peer pressure.
Peer pressure. Peer pressure is really big, especially in your teen years. And I would say that was where my journey started. I grew up in the 70s. Anyone else who grew up in the 70s know what we met. Oh, yes,
Low self-esteem.
low self-esteem. This is getting into an interesting part of starting substance use. A lot of people start substance use looking for a positive, looking to get high, looking to have fun, looking to impress their peers. And some people come to it to avoid a negative. So low self-esteem is to avoid a negative. Joseph?
To escape feelings you don't want to feel.
Right, escape feelings. This is a huge one. People use substances because they don't want to feel. When they start to get into recovery, suddenly they have to feel. And they have to try to feel without it being triggering to use. That's a really difficult thing. Yes.
For medicine, medical reasons.
Right, so medical reasons. All of the physicians in the office, here, remember in the late 1990s and the early 2000s, when we as a profession were really being influenced heavily to try to prescribe opiates for more people for pain. And I have to take responsibility for that I think we as a profession caused addiction in a lot of people. I remember, I was in the emergency department in Glens Falls Hospital at the time in New York. I was with another emergency physician. We were talking about the influences to prescribe more opiates. And we both looked at each other and said, if we continue this, we're going to have a whole generation of people addicted to opiates. Well, we continued it, and we had a whole generation of people addicted to opiates. That physician, incidentally, also transitioned into addiction medicine. Yes.
Growing up in a culture where something like drinking is just commonplace and socially expected.
So that would, yeah, a culture and family where that is the expected thing. The youngest that I have a patient who started drinking alcohol with his father when he was 3 years old. Now, how is that person supposed to avoid an addiction? Yes.
To control the pain of domestic violence.
again, avoiding a negative, right? Trauma. Most people who have suffered from an addiction have a strong history of trauma. For pediatric patients, we call it adverse childhood events, ACEs, ACE. Patients who have 3 adverse childhood events are, I don't know the percentage, just very likely to have a substance use disorder as they grow. Yes.
I was just thinking of another one, which is to cope with mental illness.
So they are self-medicating. That's absolutely right. We see that a lot with patients with ADHD. Oftentimes, they'll just start using a stimulant because that calms them down, actually.
Or the mood.
Mood state, yeah, yeah. Okay, this is excellent. But now, and I love that question, why would someone use it for substances for the first time? But I find that another question is even more interesting. Why would someone use it a second time? Yes,
Because it allowed me to get out of myself.
so you were looking to avoid the negative feelings you were having, and it worked. People continue using a substance because it works. If they wanted to feel joy, if they wanted to feel happy, if they wanted to get high, it worked. If they wanted to avoid the bad feelings of their adverse childhood events, of their domestic violence, it worked. If something works, you're going to continue to do it. It's really important to understand that people get a positive initially out of their substance use. Because if you didn't get a positive from it, if it didn't work, you wouldn't continue doing it. I was fortunate that what I was looking for when I used substances didn't work. So I stopped. But I have a lot of friends who it worked. They didn't stop. So why does it work?
Well, in the beginning, you just need a little bit.
You just need a little bit. Not at the end, do you?
You're trying to recapture either the high or forget the pain.
We're gonna do a kind of a graph type thing, okay? This is an academic. The brain passes. The brain passes signals from nerve to nerve by chemicals that we call neurotransmitters. This is knowledge that was not around when I was in medical school back in the early 1980s. This is stuff that was just learned. In fact, I didn't learn this. The information I'm giving you, I didn't learn until I had been a physician for well over 30 years. Because we didn't have this knowledge. Has anyone heard of dopamine?
Yeah.
Dopamine is one of the neurotransmitters that is strongly implicated in substance use disorder. It's a necessary neurotransmitter. Okay, we use it when we need fight or flight. Okay, we have to leave or we have to fight. And it's also tells us our nerves to have joy. So if your brain wants to tell your body to have joy, to have fun, to be happy, dopamine is one of the main neurotransmitters for that. There's thousands of neurotransmitters, okay, and I'm simplifying everything because I'm a simple person and like everything really simple. But dopamine is a huge factor here, and we'll see this. So we're gonna put here 100. And that is the high normal dopamine level, the high normal dopamine level that we have in our body, okay? In our brain. What are some, here's another audience participation. What are things that you do for fun?
Exercise.
Exercise. Thank you, Mark.
Ride the bike.
So,
Riding a bike.
so just thing that. You can only do one at a time.
Eating.
Those are all good ones. Okay, so we're gonna do exercise. So Mark gets on his bike and rides. I went for a really nice run this morning. So here's what happens to your dopamine level when you go out and exercise. It goes up a little and goes down. This, by the way, is time, okay? And this is your dopamine level. Someone said eating.
No.
Eating is big. Eating is really big. So eating, you will get up to about 150. Okay? That's eating.
How about singing?
Singing,
Yes,
we use it. Use it. Okay? No, I play the banjo. When I play the banjo, I get a lot of joy. I know my dopamine level goes up. So it's gonna go up somewhere around 150 to 200. This is evolutionary. This is really important for our survival, okay? Another thing that causes dopamine levels to be high is sex. Right? Sex, exercise, community. This is raising our dopamine levels. We do this so we can survive as a species. We need sex, we need food, and we need community, and we need exercise. All of these things are important for us to live. I love my dopamine. What happens when you, yes?
I think your microphone is turned off.
Thank you very much. I hope my voice is loud enough, but maybe it's not. Okay, what happens when we take drugs? What happens to our dopamine level? It spikes. So I wonder how much. So this is something interesting I didn't realize. Nicotine. Nicotine. I've smoked maybe one cigarette in my life total. I just coughed. But when you smoke a cigarette, your dopamine level goes up to 250. It goes higher than having sex or having a good meal. I was shocked at that. I was just shocked. Caffeine is a direct dopamine stimulant. Okay, so caffeine is going to bring it up too. Opiates are going to take it up to the 300 range. Yes.
Should they all end at the same
Oh, we're gonna get into that, okay? That's the next graph. This is academic, right? Okay. What happens when you take cocaine?
Off the chart.
Cocaine brings it up to about 500. What happens when you take methamphetamine? This is the scourge right now that I'm facing with my patients. Methamphetamine will take it up to either 1,000 or 1,400. If you can, yes,
How much dopamine do we start with?
between 60 and 100.
How does it make more?
We're gonna get into that also. That's another, that's like the fourth graph, okay? If you can take cocaine and get to 500, and you could take methamphetamine and get up to 1,000. Why would you sing? Why would you have community? Why would you eat good food? Why would you exercise? Cindy.
It's cheaper.
Well,
I just bought new running shoes. The answer is you wouldn't. And people who become addicted to substances, and this is actually in the criteria for making the diagnosis of substance use disorder, they give up community, they give up family, they give up things they like to do for fun. Those are all criteria. And it's all because of this.
Well, what about alcohol?
Alcohol brings it up about 300. Yeah, alcohol brings it up about 300 too. And incidentally, alcohol, opiates, nicotine all affect other neurotransmitters more directly than they do dopamine. But cocaine, methamphetamine, the stimulants, they are direct dopamine stimulants, and we'll talk about how that happens. Okay, we're gonna do the same graph. This is still dopamine. This is still time.
Question, Paul,
This is still 100. Yes, Mark?
the community question, people who live in these communities under tents, they have community. Now, they may get the methamphetamine on the side, but they do have a community. And that's one reason why the bulldozer doesn't help that situation.
They do have a community, Mark. That's really important. And when you have a substance use disorder and you need to use that substance or else you'll go into withdrawal, that's what we're going to talk about here coming up. You form a community around you to support that substance use. Right? You give up the community that doesn't use, and you only form a community with the people who use. So we used cocaine and we got up to here. We got up to 500 and we really like that. Okay, our dopamine's high, we have joy. What happens when the cocaine wears off? What happens to our dopamine level? It plummets. Where does it go?
Below 100.
It goes below 100. So we really like this. Because it worked. Whatever we wanted, it worked. And now we're down to here. Do we like this? No. What are we going to do? We're going to use again. And what's going to happen? You never quite get there. You do have to use more, but you never quite get there. Now, you can use more to get there, but this is what we're gonna talk about that also. So you get up here. And then what happens when it goes down from there?
Goes lower.
Goes even lower. And then you're gonna use, and it goes lower. This doesn't necessarily happen after the first use, but it certainly happens, for instance, opiates. If you're taking prescribed opiates, prescribed just as your doctor did, and you take them for 2 weeks, you become dependent, physically dependent, and you will go to withdrawal if you stop them. That's the majority of people. So, and eventually, you're down here, and you have to use just to feel normal. Okay? So if you have to use just to feel normal, what would we call this point right here? That is physical dependence. What do we call this?
Withdrawal.
That's withdrawal. Okay? Now, we're going to talk about why this happens, okay? What's happening in our brain? And this, whoop. Okay. So how does this work? This is where we're going to get into the tolerance and how these things work, okay? We have nerve A. Nerve A. We have nerve B. This is how our central nervous system works. And nerve A wants to tell nerve B to be happy. Okay? So nerve A is releasing little dopamine molecules. Okay?
Where does it get them?
That's what nerve A does. They have them stored. As it's releasing the dopamine, in order for nerve A to control how much dopamine is in the synapse, this is called the synapse between two nerves. Synapse between two nerves. Nerve A wants to control how much dopamine is in the synapse. So not only does it release it, but it will reuptake dopamine, okay? So that way it can control how much is in there. And it turns out that cocaine eliminates that. So cocaine is a dopamine reuptake inhibitor. You've heard of serotonin reuptake inhibitors, like Prozac, things like that. Well, cocaine is a dopamine reuptake inhibitor. And we said methamphetamine gets you up to a dopamine level of 1,000. Methamphetamine is a cocaine reuptake inhibitor also, but methamphetamine also increases the release of dopamine into the synapse. Okay, that's why it goes so high. So nerve A is telling nerve B to have fun. Oh, there we go. And so nerve B has these little cups. Okay. And these pick up these dopamine molecules. And when nerve B feels that dopamine hitting these receptors, nerve B feels fun, feels joy. But when we take cocaine, and now we've increased the number of molecules in the synapse, then all of these are going to get full. And so nerve B is going to feel so much greater, so much more joy. But nerve B doesn't like that. Our central nervous system likes what we call a homeostasis, where everything is within 60 to 100, 60 to 200 for good things, for fun things, okay? So nerve B doesn't really like this. So the way nerve B is going to manage that, because nerve A has already just flown the coop and it's just releasing a ton of dopamine. And nerve B wants to decrease the amount of the effect of the dopamine. So what nerve B does is eliminate receptors. Okay, so now instead of having 6 receptors, we have 3. So then that's why tolerance occurs. That's why you have to take more to get the same effect, because there's less receptors. But if you have less receptors, and then you stop taking cocaine, and you don't have so much dopamine in the synapse, then you're going to have some of these receptors that don't get stimulated. And that's why if you're dependent on substances and you don't take that substance, you feel worse than normal. Okay? So if you feel worse than normal, you're going to take more. Yes.
Do the receptors come back after someone has been in withdrawal or in recovery for a while?
Thank you very much. That is like my favorite question. And the answer is yes. But the answer is not as positive as yes. When I have a patient who's in recovery, pretty much every time I see them, one of the questions I ask is, what are you doing for joy? What are you doing to have fun? It usually takes about 2 years that someone's been in recovery before they can tell me something they're doing to have fun. But when they tell me that they're doing something for fun, going fishing, I played baseball with my child, and that was really fun. I went camping with my family, and that was really fun. That tells me that their nerve B has regrown the receptors. Okay? That's a huge part of recovery. Okay. I think we're done with this part. Yes.
To go back to your dopamine and time track, I know we were talking about cocaine then, but I wondered, because alcohol doesn't get you so high, does it take longer to reach physical dependence? Like, are those waves not so stark?
That's a good question. I don't know the answer to that one. Okay, I'm sorry. But you're right, because there's certain substances we use that directly affect dopamine, and there's certain ones that affect it indirectly. Yes.
Quick question. Is there any research regarding substances, medicines that will increase the receptors growth of nerve B, so to speak?
I'm not aware of any, but that's a good question. That certainly is one I'd like to see. Yes,
I was wondering if you could just talk about the role of Suboxone, and then also I'm hearing that the GLP-1s like Ozempic. Like, what are they doing? Or, I mean, I know they're still thinking about it, but.
yeah, let me talk about the GLP-1s. The data on that is very preliminary. But what people have found, what physicians have found, and other practitioners and patients have found that when they take GLP-1,
Those are the weight loss.
the weight loss drugs or diabetes, they start out for diabetes. And when patients take those for diabetes or weight loss, they found that their desire for alcohol, and it turns out probably other substances, decreases. And there are some data that show that people who are on those do decrease the amount of substances they use. So decrease the amount of alcohol they drink. They're starting to look at them with other substances. They're in the middle right now of randomized controlled trials to see if it's really the GLP-1 that's having that effect or not. Yes.
Statement more than a question. That just seems to me that you're just trading one drug for another drug. There's gotta be, negative effects from that somewhere eventually.
We'll have to wait and see with the randomized trials what happens. Is there, what are the side effects? And do the side effects outweigh the benefits? Do the risks outweigh the benefits? To talk about Suboxone, that's a little bit different. I'm not really going to touch too much on it today, but let me tell you. So Suboxone is what they call a partial opioid agonist. So the Suboxone, buprenorphine is the active ingredient. It sits on the opiate receptor and it partially stimulates the opiate receptor. So heroin, fentanyl, oxycodone fully stimulate the opiate receptors. And if you fully stimulate the opiate receptors, you decrease pain, you decrease withdrawal symptoms, you decrease cravings for opiates, but you can cause respiratory depression, you can cause sedation, and you can cause death with too much opiates. Buprenorphine partially stimulates the opiate receptor, but not fully. So it gets rid of cravings, gets rid of withdrawal symptoms, but doesn't cause sedation, doesn't decrease breathing. And what we found in trials for buprenorphine is that patients who use buprenorphine have decreased risk of overdose death, even if they're still using, because the buprenorphine blocks those receptors also. So that if you're taking buprenorphine and you use fentanyl, or if you're planning on using cocaine and there happens to be fentanyl in the cocaine, which there is right now, your risk of dying of an overdose is greatly decreased because the opiate receptors are blocked. So the Suboxone, the buprenorphine, has been shown to be effective to decrease overdose deaths.
If we can hold questions till the last
Okay.
5 minutes, because we're running out of time.
Okay. Okay, so we're going to talk now on the role of spirituality in recovery. How much time do I have?
Generally, and
Okay, well, we're fine. We're good. So what is the role of spirituality in recovery? When Misty asked me to do this talk, I didn't really know what the role of spirituality in recovery was. I had never really discussed it that much with my patients. Except to say that, if they went to church, I would ask them how involved they were in the church and what that felt for their recovery. But I didn't talk to all of my patients about it. And I do now, because there's some nice data behind it, okay? Let's see. There we go, okay. So some of this is hidden, I'm sorry. Oh, there we go, get that out of the way. Oh, there we go. So what is addiction? This is from the American Society of Addiction Medicine. It's a chronic disease. It's treatable. Complex interactions between the brain, we talked about this, genetics, environment, and individual life experiences. But this is where it gets really important to understand. Compulsive engagement despite harmful consequences. So we know that when you use substances, you have harmful consequences. You may get a DUI. You may suffer an overdose. You may have to get CPR. You may have to get Narcan. You may crash your car. You may lose your family. But when you're in addiction, you continue to use despite those negative consequences. You have loss of control, impaired judgment. This is kind of a complicated thing. This is the brain. Binge intoxication occurs in the basal ganglion of the brain. This is a primitive part of the brain. So the part where we get that feeling of intoxication or feeling good, that's very primitive. The withdrawal is in the extended amygdala, okay? That's pretty primitive also. The prefrontal cortex is very advanced. That's what makes us human. That's where we can take the risk of something and the benefits and make a reasonable decision. When people are in addiction, that prefrontal cortex does not work. So they can't look at those negative consequences and decide to not use. The only thing the prefrontal cortex does when someone's in addiction is helps them to get drugs. So they'll use that to say, where can I get drugs and how can I satisfy what I need? And then they get intoxicated, then they withdraw, and then they get the preoccupation, the cravings, and up and up. So this is circular. Couple interesting things. If you like podcasts, there's a podcast called The Addiction Files. I love that. Season 3, episode 56 was all on the neurobiology of addiction. Goes into much more detail than I went. There's 3 legs to the stool of recovery. I tell my patients this. If you're sitting on a stool and you've got a stool that has 3 legs, this is stable. If you have a stool that has 2 legs, it's not very stable. And if you have a stool that has 1 leg, you're really about to fall off. So my 3 legs of the stool of recovery are medical treatment. That's what I do. Mental health or substance use counseling. And here's the key, is peer recovery support. Okay, that is building a community of people who are in recovery that can support your recovery. That may be meetings, and we'll talk about those. What is spirituality? And this is from the Spirituality Interest Group of the International Society of Addiction Medicine. It's a commitment to a transcendent or existential personal meaning in one's life, involving a connection, something larger than oneself. So this doesn't talk about God, doesn't talk about Jesus, doesn't talk about church. It talks about your mind and your heart and making a commitment. Let's talk about recovery capital. This is something that I track in all of my patients. And forget this first paragraph. What I tell patients is, how are you building your life to support recovery? Okay, what in your life is going to support you in recovery? Remember, patients who are suffering addiction have lost everything. We saw that in today's gospel. They're in the ditch. They're broken. They're in pain. They're alone, or they're with people who use. Social capital is their relationship that they build as they're in recovery. Community involvement is important. Physical capital, really key. Stable housing. So many of my patients were unhoused when they were using, or couch surfing. Financial stability, having some source of income to provide for the basic needs of life. Have access to health care for your physical and mental health, and transportation. Human capital, these are the skills that you learn in recovery and through counseling to support your recovery. And here's the key when we talk about spirituality, is cultural capital. Developing values that support recovery, such as 12-step programs and other spiritual or cultural practices. There is spiritual recovery that doesn't involve 12 steps. A sense of belonging and purpose in yourself and your community. Let's talk about 12-step recovery. We commonly think of this as Alcoholics Anonymous. There's other forms, we'll talk about those. But it's a fellowship of men and women who offer their hope, strength, and experience to anyone desiring not to drink. Now, most of the AA meetings in this area have patients with alcohol addiction, opiate addiction, cocaine addiction, because the addiction itself is pretty the same. You just are substituting different substances. So this was started by Bill Wilson and Dr. Robert Smith in Akron, Ohio, in 1935. The story I heard of this is that Dr. Smith was in Akron for a medical conference. Dr. Smith had alcoholism, and he was suffering, and he needed to talk to someone. He talked to someone in the conference, and they referred him to this Bill Wilson who lived in Akron. And they got together and just to talk about their recovery and their alcohol use. And that was so moving to both of them that they formed AA in 1935. I was not there, but that's what I've heard. So what do we have? We have Alcoholics Anonymous, we have Narcotics Anonymous, Cocaine Anonymous, Marijuana Anonymous, Gamblers Anonymous. There's a whole bunch of them. Al-Anon for affected others, family members, friends. And Alateen for teens with substance use. Yes, teens can develop this addiction early on. And then there's other recovery meetings that are different. And SMART recovery is one of those. I don't know a lot about SMART recovery. So these are the 12 steps of recovery, and I'm not going to go through all of them, but there's a lot that talk about God. Number 3, number 5, number 6, number 7, talk about Him referring to God. Number 11 and number 12. But look at number 11, God as we understand Him. So for us, for Christians, we have our God, we have Jesus. But there's some people who believe in other religions or are atheists. And people with agnostic or atheist beliefs may be hesitant to participate in 12 steps. And some of my patients that don't have a strong religious belief are hesitant to go to these 12-step recovery due to the religiosity. I work at the residency with this wonderful human being who's a peer recovery coach. I was talking to her about this. She said, and she's very active in the 12-step program. She's a sponsor for several people. She's a sponsor for some of my patients. She said that there's so many things that can be that higher power. And she says, if need be, just the community of the people in the 12 steps, that's your higher power. What we want to do, and I know I'm sure you want to do that, is to make this more open so that everyone feels comfortable. There's patterns of involvement in 12 steps. There's those that are initially very involved and then over time taper out or taper down. There's those that start off good and stay steady involvement for years. And then there's more that kind of are variable. They come and go. It turns out that the science shows that the more consistent people are in participating in the 12-step programs, the better outcomes they have, the more likely they are to be abstinent and for longer periods of time. And I put in the little footnotes there of the studies. This is interesting, and I know this is me. If a patient has my team needs attention. If patients are not religious in the past, I wouldn't talk to them too much about the 12 steps, or I may mention it and they'd say they're not interested and then we'd let it go. That doesn't happen anymore. Patients with agnostic or atheist beliefs attend fewer meetings, but the number 3 is really important. Patients who go to AA increase their religiosity, increase their spirituality, regardless of their initial beliefs. And this is the most important thing. 12-step programs lead to positive outcomes. So people who attend 12 steps, they're more likely to have total abstinence. They stay in recovery longer. They build more community and their lives improve. And that's really what this is all about. It's my job, I say, is 2 things. I don't want my patients to die, and I want their life to improve. The third goal I have is for them to stop substances. But more importantly, I don't want them to die, and I want their life to improve. We don't know, there's never been a study, and you can imagine why this would be hard to do. We don't know comparing AA to counseling, comparing AA to counseling and AA, comparing AA to medication and counseling. We don't know that. It's very hard to do randomized controlled trials in the substance use community because patients who are using substances, their lives are chaos. And remember, I said randomized control, they have no control in their life, so you can't do a really good controlled trial. This is really important, and in the 12th step, it talks about a spiritual awakening. And patients who have a spiritual awakening in recovery associated with a greater percentage of total abstinence, and not by a little bit, by like 30, 40%, much higher. I've been talking to my patients who are spiritual and even the ones that are not, and I ask them, you know, what does spirituality mean to you? What does it mean for your recovery? And these are what I got. When I'm with God, I'm never alone. And I remember Joseph talking about God is in me. So when I'm with God, I'm never alone. My religion gives me hope for the future. My church is a community of support for my recovery. Grace Christian is certainly a community of support. My faith is everything for my recovery. Without faith, I would be dead. This is from a patient of mine who's almost about my age. He's married for a long time. Just retired from driving a tow truck. He's got children, grandchildren, and a great-grandchild. And he says, without faith, I would be dead. This last one is something that a patient told me this week. This is a patient who's unhoused, but he's told me before how spiritual he is and he likes to go to church. And I asked him, are you going to church? And he said, I can't. Because, and I said, well, are they not welcoming to you because you're unhoused? And he said, no. He said, in order to honor God, I have to treat my body well. If I'm not treating my body well, I'm not honoring God. And therefore, I can't go to church because I'm too embarrassed about my action. That hit me really hard. That's my talk. Yes.
All right, my question, this may be understandable, you talked about what was the frequency of this was in some step process of AA.
Bye-bye.
What? So, and I wonder about the scientific side of this, and whether there's any data that would show changes in the brain with say meditation or with a spirit, an obvious spiritual exercise where you might see a change in dopamine, a change in some other hormonal or neurotransmitter.
Yes.
So in other words, is there any evidence?
Yes, there
Okay,
is.
good.
I don't have any data that I could find on the neurotransmitters of spirituality, but they have done functional MRIs on patients in meditation having spiritual sessions, and parts of their brain light up. And it's interesting, it's different parts. There's quite a bit in the prefrontal cortex. There's also in the temporal and parietal lobe. It's interesting that it would be temporal and parietal lobe because those are the lobes I think of as causing us to function, to move, to get up and go. Whereas the prefrontal cortex is the one, the thinking, where we make choices in our life. So it's interesting that it hits on different parts of the brain, but yes, there is that data. There.
Lori, how many of your patients, what percentage of patients gain insight in their recovery as to why they started using in the first place?
I think most of them do because we talk about it. We don't do it, I don't do it the first time, but after they've been in recovery for a while, I ask them, what do you think caused this? And just the stories of their adverse childhood events or the trauma they've been through are just horrific. Just horrific. Yes.
When you're talking about spirituality today, there's the focus on the individual, the spirituality of the person with the addiction. I work with, as a therapist with, people who are addicted to multi-substances. And I'm thinking spirituality in terms of the community. How can we best help them as the system? Because so many of them have been incarcerated and carry the label of felon. And we can just see how their self-esteem and their trust of others is just shattered. And so I'm just wondering, as a church community, how best could we challenge the legal system, maybe to look differently to help those with addictions?
I haven't thought about how we can challenge the legal system, though I do that a little bit. I like to cause a little trouble. But what can we do? Number one, that's why I gave that talk on neurobiology. Decrease stigma. Be welcoming to people who have substance use disorder. I love my job because my patients are the most loyal and grateful patients that I've ever had in the emergency department. You know, once in a while I'd get a card, a letter. I get so many Christmas cards and just thank you cards from my patients. They text me in the middle of the weekend just saying, we're down at the lake, we were just thinking of you, and I'm, thank you. It's amazing. Be open. You have angels in the ditch. Yes.
Is there more training in medical schools now for addictive medicine than there was, let's say, 50 years ago in my generation?
A little bit, not a lot. The question is there more education in medical schools for addiction? Not a lot. I am so happy that I work at the family medicine residency because I get to work with medical students from University of New England and residents and teach them about addiction. And they love it. They're so enthusiastic and they love it because they get to see patients get better. You know, when they're treating people with diabetes, with hypertension, with chronic CHF, they don't see people get better. Maybe a little bit, Mark. But people with addiction, when they get better, it's amazing. It's just amazing.
I think we have time for one more question.
Yes.
Oh, no, it's okay. Go ahead. Yes.
Has medical science proven addiction to be a disease?
To me, it is a disease. I think that it doesn't matter what you call it. It matters how you manage it and how you treat it and how you treat the patient, the person with the disease. Okay, so you could call it condition. I call it a disease. That's because I'm a physician and the American Society of Addiction Medicine calls it a disease. Can I do one more?
Yeah, she's a nurse.
My interest and question is about teenagers and the use of marijuana. And does it lead to them? I mean, what makes them stop? What makes them not go on? And this could be a whole different.
That's a whole different talk. I will tell you, marijuana, cannabis is just one of my it just is a pain in me. In the 1970s, when we were smoking marijuana, the marijuana we would smoke was about 1% THC. If you go to a cannabis store right now, the marijuana you get 20, 40, 60% THC. So I tell my patients, if you're smoking one joint right now, that would be like me smoking 20 joints before I went into high school to take a test. So we're just starting to see the effects of this high potency cannabis right now, and it's not good.
Could we give? Thank you, Paul. Just a couple of housekeeping things. If you're a visitor and would like to be on the email list for our events, we won't tell you about church and we won't ask for money. We have a special list, just if you'd like to be invited to events like these, you can sign up on that back table.